I would like to welcome Dr. Sriraj V, the clinical lead of AMS team, for the welcome address.
Thank you. Good morning all. A warm welcome to you all. അന്ന് ഓർത്തോയിലെ മീറ്റിങ്ങിൻ്റെ ഭാഗമായിട്ട് ഒരു ക്ലാസ് അറേഞ്ച് ചെയ്യാന്നുള്ളൊരു പ്ലാനിൽ വി ഇൻവൈറ്റഡ് ഡോക്ടർ സ്നേഹ റിക്വസ്റ്റഡ് സ്നേഹ ഫോർ ഗിവിങ് എ ക്ലാസ്. സ്നേഹ അഗ്രി ചെയ്തു. I welcome all of you for the class. I invite Dr. Sneha. Sneha is actually a clinical fellow in antimicrobial stewardship and infectious disease in Aster Medicity. Welcome.
Thank you, everyone. Thank you for inviting me for this presentation, especially to the AMS team and Dr. Sriraj. So I've actually made a very brief presentation. It's quite concise, and I hope I made justice to this topic. Okay, so basically I'm going to discuss on these three major clinical syndromes, that is native joint infection, osteomyelitis, and implant associated infections. So under native joint, we have acute bacterial arthritis, chronic infectious arthritis, osteomyelitis. You have in general vertebral osteomyelitis as well as the open contaminated fracture. Implant associated, PJI and internal fixation associated infections. So basically, this is my approach. It's a case-based approach. I'm not going into the details of the clinical features and the radiology. Basically, I'm going to talk about move towards the ID side. So I'm going to talk about the microbiology part. How do you diagnose it? What all are the specimens sampling that is needed? And also I'll just go through a brief guideline review and the treatment aspects. So first case, we have a 45-year-old man who's a known case of diabetic, who's on OHA, and he also has decompensated chronic liver disease. He has now presented with fever for the past 1 week and also along with acute onset disturbance in the sensorium. He was admitted in an outside hospital with fever and cellulitis of the left leg, and there his report has also shown a blood culture growth of Streptococcus agalactiae, and we do not have the AST report in his discharge summary. Now on examination, he slightly has tachycardia and a low BP that has been corrected with IV fluids, and the total count is around 10K with a CRP of 124. His left leg now is swollen and it looks like cellulitis, whereas his right knee is also swollen with erythema. Now from here, there's a preliminary diagnosis of septic arthritis being made, and we have sent the blood cultures and started him on ceftriaxone teicoplanin. So we'll just go through how are we going to diagnose this, as well as why we made this choice of ceftriaxone teicoplanin. Okay. It's not working. So coming to the microbiology part, as you all know that it is the gram-positive organisms which are the most common that we find in septic arthritis. So this is a small table that you see here that shows you the most common, and the most common always is Staph aureus, and then it's followed by streptococci, and only in certain cases do you see gram-negative bacteria. So where do you see these gram-negative bacteria? It's only in 5 to 20% of septic arthritis, and it's mostly associated in the immunocompromised as well as neonates, and especially when there is a history of previous orthopedic surgery. Now, how do you diagnose this? So you all know, you send the routine bloods, especially you see elevated WBC, ESR, CRP. Now remember, also send blood for cultures, because around 25 to 70% of blood cultures can come positive when you have a Staph aureus infection. And what is the role of procalcitonin here? So you know about serum procalcitonin, it helps you identify bacterial infections. So you have a number of articles. So this article focuses on bacterial septic arthritis, and it shows you that a higher procalcitonin values does correlate with when you have a suspected septic arthritis with a differential of crystal arthropathy, etc. But the drawback is that if you have a normal procalcitonin value, it still doesn't rule out a septic arthritis. So next step is an arthrocentesis. You take the synovial fluid to do a total count, differential count, gram stain, as well as crystals, and you'll go for culture and sensitivity. And this culture and sensitivity, you can include a fungal culture, and you can send it. I mean, they actually recommend to send it apart from the conventional culture and sensitivity in blood culture bottles. So it goes into automated blood cultures, and that also has shown a higher yield than your conventional cultures. And also there are molecular workups that can be done. So right now, yeah, so BioFire, you must have heard about that panel, BioFire. So BioFire has also come up with a joint infection panel, like your blood culture panel and your CNS meningoencephalitis panel. So this joint infection panel can be used to diagnose septic arthritis or prosthetic joint infections, but it has not yet been validated, and we're currently validating that in Aster. So that is another one option that's coming up. Now, coming to the treatment, obviously you need to drain the joint as well as start with the antimicrobial therapy. Now, this is a general algorithm. So basically, when you have a clinical suspicion of septic arthritis, you send the routine labs, you go for a joint aspiration, you send that for gram staining, cell culture, glucose imaging. You basically you consider MRI, and you can consider antibiotics following the aspiration. So remember that it's not about starting immediately, but better to take an aspiration and then start the antibiotic. So if you have something in the gram stain, you can actually start specific to the gram stain, like if they report a gram positive cocci or a gram negative cocci. But also remember, gram stain sensitivity is quite low. It's like less than 50%. You mostly won't have that. You'll have a negative gram stain. And basically, then you need to look at the WBC count in your synovial fluid. If it's more than 50,000, you better start with the broad spectrum empiric antibiotics. So these are the common organisms that you find. So your antibiotic should be covering quite whatever you find, which is most common. So what we most commonly find are gram positive cocci like Staph aureus. So I don't know if you use vancomycin here. We don't use that in Aster so much because it has a lot of renal side effects and other toxicities. So basically what we use there is teicoplanin, and we add that to a general gram-negative cover of ceftriaxone. Or sometimes we go to piperacillin, which is actually a better gram-negative cover for, as it actually covers pseudomonas, etc., other gram-negative organisms. So yeah, so you can initiate this broad spectrum antibiotic, and if the cell count is less than 50,000, you can actually wait for the culture results, that is up to 48 hours, and then if there is anything that is growing, you can actually start with the culture specific antibiotics, and also move on to the surgical intervention part, which is an important part. And yeah, here you can go for arthroscopy, arthrotomy, whatever, and you can drain the joint. And based on the final sensitivity reports, you will need to adjust the antibiotics. So now coming to, initially you will be starting with an IV antibiotic. What is the duration? Basically, this is where you have the least duration in bone and joint infections, that is 2 to 4 weeks. All others you have to treat it for more than 4-6 weeks, etc. So minimum is 2 weeks, except in cases where you have an MRSA or a gram-negative infection, or when you have an immunosuppressed or compromised patient where you need to go for 4 weeks or more than that. Now, the oral to IV switch can be made within, actually they suggest making it within 3 days, but commonly it's practiced around 5 to 7 days. And the rest you can actually, if there is a sensitive antibiotic, or if you're empirically started, you can move on to any quinolones, etc. Okay, chronic infectious is just a short note on this. So you have mycobacterial infections as well as fungal infections that can cause chronic infectious arthritis. So you all know mycobacterial, it causes chronic granulomatous monoarticular. The synovial biopsy is more sensitive than taking a fluid when it comes to this, and you need to send it for AFB smear, culture, gene expert, as well as the histopathologic examination. So chronic infectious arthritis not only includes tuberculosis, it also includes the non-tuberculous mycobacteria, especially if it is seen in steroid injection users, or where there's been a person who has already had a surgery done even a few years back. And for TB, the treatment is a 4-drug plus 3-drug regimen that's going for 6 months, and it can increase. And for non-tuberculous mycobacteria, it basically combines macrolides and aminoglycosides, etc. That goes for 12 to 16 months. Now, coming to the fungal infectious arthritis, again, it's more commonly seen in the immunocompromised, chronically ill, especially if you have a central line catheter in a patient who's been admitted and then comes back. So mostly here, we see Candida species and followed by Aspergillus, that's rarely seen. Now, Candida arthritis is usually associated with candidemia in 30 to 50%. Again, the importance of sending blood culture. And you also need to look into endophthalmitis, which is rarely actually seen. And initially, you can start these patients on echinocandins, that's your caspofungin or micafungin. And then later, based on sensitivity, if it's available, you can change it to azole, even oral, and or you can just start it straight away with azole alone, but you need to treat fungal arthritis for at least 6 weeks. Okay, so any doubts in the previous? Yeah. Initially, like I said, empiric only, empiric and yeah. That is mostly there for a definitive therapy. Usually we start with ceftriaxone in case the patient has a high risk of Staph aureus infection, like the orthopedician tells us joint looks really inflamed and there's a lot of pus. In those cases, yeah, we start with teicoplanin. Vancomycin is less preferred.
You recommend to go with a higher antibiotic first?
Yeah, and then you base it on the culture sensitivity and then bring it down.
Okay.
But
second thing is, we are having this diabetic patient with swelling of the leg. And how can we rule out necrotizing fasciitis initially? Develop early phase of necrotizing fasciitis.
Basically, again, ultrasound or something can be done, so it can actually.
Is there any guideline for that?
There's no such guidelines for that.
So we can. It is just an.
Yeah, it's a clinical basically
diagnosis.
Clinical and imaging.
Vancomycin start ചെയ്യാം. Okay.
It is said that 6 months is not enough.
Yeah. It's more than 6
Yeah,
months.
yeah.
For bone and joint infections, TB is
Yeah, yeah.
generally given more than 6 months.
And regarding what is the CBNAT, CBNAT is something which is
Yeah, gene expert.
this comes
So
under
that is very,
comes under
it's a very rapid test. So actually, once you send the sample, I mean, like the TAT becomes around 4 hours to 5 hours to diagnose TB. So that
CBNAT,
is,
it is so fast.
yeah.
So we are sending to some government, I think,
If you have a higher load of suspected TB
Yeah.
arthritis, especially it's endemic in India. So gene expert comes in two forms. You have the normal gene expert that is for the pulmonary TB, and you have the ultra. So ultra has a higher sensitivity, it detects even lower bacterial TB bacilli. So we use ultra for these extra pulmonary TB samples. So the result comes within that day. So we can actually start with the ATT.
So possibly.
Yeah, total.
Roughly 1 week is that. I thought it was. I was not aware to such a fast method of dictating. And what is NTM?
NTM is non-tuberculous mycobacteria. So that is that will come as AFB smear positive and gene expert negative. So the PCR part will be negative. So the smear comes positive, and even in the histopathology examination, you can see that.
And you are saying something about some fire.
Biofire.
Biofire.
Actually, I had the slide. I don't know. It's not there now.
So what is,
So Biofire is actually a panel. It's a multiplex molecular PCR panel. So it's a
So
PCR.
it's a PCR
so
basically.
it's basically
Just,
detecting
yeah.
number of genes.
Oh.
So I think it's there here. It's yeah. The bacteria is identified, and along with that, you also have the resistance, antimicrobial resistant gene is also detected.
So from that you can have an idea about which antibiotic you have to start.
Yeah.
Okay. So it is here. What is it?
But not for joint. For different panels are there, sir, for Biofire. So it's there for blood. It's there for CSF. It's there again for respiratory samples. So now they have started with the joint infection. So it's not actually validated.
Different panels will be fungal, viral. Okay, thank you. Available ആണ് പക്ഷെ നമ്മൾ പസ് പറ്റില്ല.
No. Actually, right now they have not validated it. So we are actually validating it in Astra. So we currently run it only in 7 samples, and they want a clear fluid which is not really turbid or thick. So with that, out of 7, we identified 2 Staph aureus arthritis.
That is, we are routinely doing. We have started doing that, and they get as you said, it takes 1 week, but that is not bad. But we can do that here. അത് ഭയങ്കര കോസ്റ്റ് ഒന്നും ആവില്ലല്ലോ. എന്നാലും നമുക്ക് LTP ആണെന്ന് സ്റ്റാർട്ട് ചെയ്യാം. ഫ്രീ ആണ്.
You can actually send it like a panel where you do AFB smear, culture plus a CBNAT if you have TrueNAT, that also. So you don't miss out. I mean, it can come CBNAT negative, but smear and culture positive. Quite rare, like I said, only in steroid, where you have these intra-articular steroid injections, or in maybe immunocompromised. I have only seen 2 septic arthritis like that. And it's a very long duration of treatment, and growing that is another difficulty again. So yeah, usually, yeah. I mean, apart from arthritis, NTM is there and pulmonary and all that. That we do get, but arthritis till now, I mean, in the past 2 years.
How will you proceed further? Do you look for PCR-based species identification, or you wait for the culture to identify the patient?
Culture. You do have direct PCR,
Yeah.
but that is very costly, and we need to, for us, we need to send it to a place where they do gene sequencing type. And once it grows in the culture, and most NTMs that you get are rapid growers. So in 7 days, they do grow. Otherwise, within 2 weeks, they'll grow. So then that we send it for something known as MALDITOF. So that will give you a rapid identification. And for each species, you will have a different regimen to follow. And duration is again based on the clinical syndrome.
Whole genome sequencing is also available. Around 5,000 rupees. You can get your reports like this and name and all. That is based on species. You have a whole genome sequencing.
Whole genome sequencing, it's there in different places. Amrita, it's there.
Amrita is doing the target based.
Amrita, I think, charges 5,000 something for whole genome. Yeah. For isolates. No, from the culture isolates, whole genome sequencing. Direct sample is not actually so recommended. Culture isolates. Okay, so I'll move on to the next topic. So next we have a 76-year-old woman who is a known case of diabetes mellitus and systemic hypertension. She has undergone percutaneous coronary angioplasty 3 months ago. Now 2 weeks after the procedure, she starts developing low-grade fever for 2 to 3 days, and 3 weeks later, dull aching pain in the lumbosacral region, and this has been progressively worsening. Now she also has weight loss, and right now she is afebrile with stable vitals. She has a moderate tenderness of the lower back, and her motor and sensory examinations are intact. Now ESR and CRP is raised with mildly raised counts of total count of 8K. Now the CT scan shows marked decalcification of L4, L5 with moth-eaten appearance of the L5 end plate. Now an initial CT guided aspirate is done, which is actually negative for culture, and the TB workup. So TB workup, like I said, the AFP smear and the CB-NAT or gene expert. And again, the blood culture which has been sent is showing a no growth in 72 hours. Now, now this is a probable diagnosis of vertebral osteomyelitis. Now, a repeat aspirate is indicated in such patients, and now a repeat aspirate was sent, and this has grown Staph aureus, which is sensitive to cefoxitin and quinolones. So generally talking about osteomyelitis, your microbiology is mainly dependent on the source. So if it's in hematogenous source, it's going to be monobacterial, and the most common, again, most of your bone and joint infection is always GPCs. So mostly, again, it's Staph aureus followed by streptococci, etc. And when it is a contiguous, that is, there's a skin lesion that is associated with it, it's usually polymicrobial. So again, your empiric choice is going to change here. If it's polymicrobial, you need to go for a little more broader spectrum. And depending, again, it always depends on the clinical condition of the patient. If the patient is on sepsis, septic shock, etc., you need to start with the higher antibiotic like meropenem, etc. So yeah, basically, if the patient is stable, you withhold all antibiotics until your percutaneous aspirate or surgical culture has been obtained. And what are the cultures that you can send? You can even send swabs from a discharge sinus or wound. Now, generally, you don't suggest swabs. It's not recommended to send swabs. But when it is osteomyelitis, since it is a deeper infection, especially when it is Staph aureus infection, there is a high correlation between a superficial swab and a deep surgical culture. So for only this case, you can send a swab to the microbiology. So you are justified for doing that. Otherwise, swabs are not recommended. So also, when you have a draining sinus, it has relevance in infection prevention control, you'll need to isolate the patient when it is an MRSA or an MDR infection. And again, like I said, it correlates well with the deep surgical culture. So that's why you're actually justified in sending a swab. And you also need to send blood cultures and deep surgical cultures whenever you're going in for a surgical intervention. Now, again, the treatment, antimicrobial therapy alone is not going to work. You will need to go for a surgical intervention, and again, a combination of beta-lactam or vancomycin and teicoplanin. So these are the common organisms that you get, and what are the antibiotic choice that you need to make when your culture is positive for any one of these. So in case of Staph aureus, if it is methicillin, I mean, you all know about methicillin sensitive and resistant. So in this case, we saw it was cefoxitin sensitive, which means it is methicillin sensitive. In that case, you can actually go for cefazolin, which is more widely available here. And whereas when you have MRSA, these are all US guidelines, so that's why they mention vancomycin. Here we commonly go for teicoplanin unless the patient is already on dialysis or it's a younger patient. In those cases, you can go for vancomycin. It's a lot cheaper. And you also have daptomycin. So alternative choices for MRSA, again, linezolid, where you have an oral option, so you can actually convert it into an oral soon. And but also remember, in most of these cases, when you have staphylococci, you always add rifampin. We have rifampicin, so as a 300 OD dose, you add it along with the oral drug, and after the initial IV treatment. So when it's streptococci, best is penicillin, but we generally don't use that because of its very shorter interval of dosing. It's 6th hourly usually, and mostly we go for ceftriaxone or piperacillin tazobactam. And enterococci, streptococci, again, almost the same, unless when you want to cover the, there's something known as a nutritionally deficient streptococci, which actually very slowly grows in blood cultures and bone infections. So in that, again, if it is penicillin sensitive, well and good, you can give penicillins or piptas. And next, very rarely you see these gram-negative organisms unless they have been operated previously or they had a long-term admission in the hospital, etc., or an immunocompromised who have they are being admitted again and again in the hospital. So yeah. So again, you're having a long duration of treatment, 4 to 6 weeks, and when you're giving antibiotics for 4 to 6 weeks, you always need to remember about resistant development. So if the patient is coming back again worsening with worsening symptoms, etc., you might need to send again a repeat sample to look for resistance. And adverse drug events. So especially when you're giving an oral drug like linezolid, so these are drugs that can cause you bone marrow suppression. So you will need to monitor the patient weekly for any such adverse drug events. Now, when you have a non-operative case, long-term suppressive therapy can be given. If you have any culture reports which is sensitive to quinolone or clindamycin, these are the ones which are preferred. Otherwise, even when you don't have, if you have a culture negative, that I'll be talking about next, even for that you can give quinolones. So coming to culture negative osteomyelitis, so this is where what do you say, you don't have an option. You initially start with an empiric IV, mostly like ceftriaxone, or if you have what do you say, a patient in sepsis and all that, then you start with meropenem, teicoplanin, and then you again need to go down. So when you have a culture negative osteomyelitis, if you've not done a mycobacterial and fungal study, you better do that first. And then you also have this 16S RNA sequencing, which is a molecular workup, almost like your whole genome. Not like that, but you have a sequencing that is again done in Amrita and few other centers. So again, when you have a culture negative osteomyelitis, you can actually, studies have shown that clinicians have done the IV to oral switch earlier. So, and usually this oral antibiotic is a quinolone, and especially moxifloxacin, because moxifloxacin has a higher anaerobic cover. Or you will need to go for a combination of beta-lactam with a clindamycin, etc. So coming to this vertebral osteomyelitis, so again, as usual, it is the gram-positives which are more common, but we need to rule out Mycobacterium tuberculosis in our setting, and also Brucella. You must have heard of brucellosis, so that usually comes through unpasteurized milk. It is not so uncommon. It is there, and usually you diagnose brucella with serology. And also in case of immunocompromised or IV drug users, which we don't see, and post-op where you have a history of surgical intervention done, in those cases you need to look for GNB and Candida, and maybe even cover for it if the patient is not responding to your initial empiric treatment. And in HIV, again, you need to think of non-tuberculous mycobacteria. So again, diagnosis, your usual routine bloods. Here mostly it is ESR which is going to be raised than your CRP or procalcitonin. Now your blood culture, you will need to send 2 sets, because your most common organism is Staph aureus here, and usually Staph aureus is related to infective endocarditis. So you need to screen for infective endocarditis and send 2 sets of blood culture. Actually it's 3 sets, but initially you need to send for 2 sets. And you need to rule out TB as well as brucella. Brucella serology is IgM as well as agglutination test. And you also need to rule out TB, so you might have to do the latent TB testings. And fungal blood cultures can be sent, which is actually separate from your normal aerobic and anaerobic bacterial cultures. And you will need to do an image-guided aspiration biopsy. Now, your treatment again is antimicrobial therapy, and in whomever it's possible, better go for a surgical intervention. And again, your minimum duration of treatment is 6 weeks. More than 6 weeks is indicated for methicillin-resistant Staph aureus infections when you have an undrained abscess or in case of end-stage renal disease patients. Now, in brucella, brucella is important because you need a longer duration. So, and you need specific antibiotic cover for it. So otherwise the patient is going to come back to you with the same complaints. And what are the indications for surgery? You have your indications, that is your instability of the spine or progressing neurological deficits, etc. And apart from that, if you have recurrent bacteremia and a worsening pain in the patient, etc., then again you will go for you need to go for a surgical intervention. So any doubts in osteomyelitis? Yeah. Yes, sir.
Suppose I am thinking about epidural abscess because patient is relatively immunocompromised, diabetic, had a invasive procedure. So if my initial diagnosis is epidural abscess, does that change the what should be the approach?
Your choice is basically almost the same, except if a procedure has been done, you need to cover for gram-negative bacteria, and if that is not responding, you might look for a Candida
Does the
infection.
indication for surgery change?
Indication, yes. Abscess have to be drained, because otherwise it's going to stay there. It can lead to bacteria.
So initially, is it better to take a CT or MRI?
MRI is...
So if we suspect such a patient, we have to take an MRI first.
Imaging, I have not actually focused on the imaging part. I've focused on the infection, microbiology part. So...
You did not mention about Burkholderia pseudomylia, because our diabetic patients' load is very high. And we have seen cases with osteomyelitis as well as joint infection. My question is, which antibiotic, how far?
For pseudomyelin, if you don't have the sensitivity, start with meropenem. And then once you get the sensitivity, if it is sensitive to ceftazidime, then downgrade it to ceftazidime. And if it is, yes, ma'am. Again, if it is, you have an oral option of Septran, cotrimoxazole, you can actually add Septran if it's a severely sick patient. And for osteomyelitis cases, again, pseudomyelin, you will need to treat more than 8 weeks. Huh? 3 months, more than 3 months. And then it starts with it starts with the initiation phase and then it goes into a maintenance phase. Maintenance phase goes for 6 Septran for maintenance. Okay, we give Septran mostly if the patient is tolerant to that. Otherwise, we give amoxicillin.
Good morning. That was a wonderful presentation. Let me introduce myself. I am Dr. Scott, a spine surgeon over here. I think we have done hundreds of cases related to osteomyelitis here in Amala. We often have the diagnostic dilemma. I have presented this in various conferences where MRI comes as tuberculosis, or maybe last week that patient, the MRI was diagnosed to have malignancy. And finally, we planned to open it up. Of course, he was 75-year-old and we opened up and ultimately there was pus. So the main diagnostic dilemma is to get the diagnosis. I think MRI, whether you do CT, MRI or everything, you never get a diagnosis without any tissue, histopathology and also, of course, culture. But in case of osteomyelitis, most often we get a sterile culture, even though there is lots of pus over there and lots of granulation tissue, everything. So we may be treating some cases empirically. And I would like to also mention some point, whether it's described in maybe literature, not in textbooks. We often put local antibiotic, where there are studies which shows that there is 200 times increased concentration of antibiotics at that site, especially vancomycin. Of course, it's maybe a bit controversial, but there are lots of papers are coming up in, especially in our spine journals, that local vancomycin has got definitive role in preventing the progression of the infection. As far as surgical this thing is concerned, we are mainly concerned regarding instability rather than your infection, honestly. So of course you need to decompress all these things, but if there is an unstable spine, it has to be fixed, whether it is tuberculosis or tumor or infection, osteomyelitis, or we call this mainly as pyogenic spondylodiscitis. That is what we call. I don't know whether the term vertebral osteomyelitis is right or not. I don't know, because it often affects the adjacent disc. So we often call it as pyogenic spondylodiscitis. I don't know from where you got this vertebral osteomyelitis. Maybe you tend to differ, I know, but it's mainly the end plate involvement, adjacent level involvement. So I believe in putting local antibiotics, and if we suspect TB, we often put local streptomycin.
Okay.
And regarding antibiotics, 6 weeks is the course, and we often use linezolid. I think Sriraj tend to differ that. But we like to use linezolid because vancomycin long-term treatment is all difficult in our kind of setup, and patient want to get some oral antibiotics.
Linezolid has a good oral bioavailability and tissue penetration.
Yeah, even if it is MRSA negative.
The sensitivity depends. Like you said, we also see a lot of culture negative.
Yeah,
but,
sure.
Once usually Staph aureus grows, the sensitivity is quite good.
Yeah.
So usually if we have such a case, we move on to a quinolone, like moxifloxacin and all that.
Okay. We do, now we started using a lot of clindamycin recently, so it's doing well. Thank you.
Thank you, sir.
Two more questions. For non-tuberculous mycobacteria,
Yes, sir.
is the treatment same or is
It's different, sir.
Yeah, what
So, non-tuberculous mycobacteria, you have different types. So, you have rapid growers and then you have the other late growers. So, again, for each species, it differs. So, it's actually a combination of macrolides, aminoglycosides, etc.
so not to the
No,
routine?
it is
and-
not HRZE. Ethambutol can be there in some of these, and you combine all of this, and then the duration goes over a year, usually 18 to 24 months, etc.
Another doubt is regarding, though in the discussion you told about the cotrimazole, in none of your charts you didn't show that.
Yeah, actually, in those are all US, what do you say, US guidelines. But even there, cotrimoxazole is used, but the tissue, when it comes to the tissue penetration, bone and tissue penetration of Septran, it is good, but there are other better options like linezolid, etc. for that.
The
And
cost is, the
beta-lactams.
cost is something.
It's actually very low.
Yeah.
It's,
And,
but the side effects are quite bad.
That is right. You have to be very much vigilant. But at the same time, because I find it difficult to get this now in the ഇപ്പോൾ ഉണ്ടെന്ന് തോന്നുന്നു പക്ഷെ ചിലപ്പോൾ കിട്ടാറില്ല ഈ കോട്രൈമോക്സോള് ബാക്ടീരിയം പക്ഷേ ഞാൻ ഉദ്ദേശിച്ചത്. Then other, you have shown that penicillin do have a role. Now something which everybody is forgetting.
Yeah. If it is sensitive, penicillin is a good drug. Yeah. Provided there's no hypersensitivity.
I have a doubt. This one. So we empirically started a gram-positive coverage along with like ceftriaxone plus linezolid we started for osteomyelitis. Now the cultures came sterile. Like in our practice, we start linezolid along with another antibiotic. Now, when you recommend stopping if the culture is sterile and there is no infective endocarditis, no evidence of Staph aureus infection as such, you recommend stopping linezolid and continue the other moxifloxacin long term?
If
or
the patient has responded well to your linezolid and gram-negative cover, you can go with linezolid and quinolone or
for the continuation of completion of treatment.
It's better to go with the combination that the patient has responded to. But if the clinician who's ever operated has told you that it doesn't look like, what do you say, pus, it's not really thick pus and it could be something like an NTM and all that, then you can go for a moxifloxacin combination. But again, moxiflox, you combine it with linezolid. So that's actually a really broad spectrum to cover. Yes, sir.
Drug, or should we wait for the culture?
If the patient is stable, you can wait for the culture.
Yes. If only the culture is positive, then only our
And
diagnosis
your
is confirmed.
histopath is very important.
Yes.
So it actually tells you information like neutrophilic
Better
inflammation.
if there is a pure vertebral osteomyelitis, there is no systemic symptoms, better not to start an
You can
antibiotic.
wait actually. Unless it's an immunocompromised patient or
Make every effort to get a clinical routine diagnosis.
Usual duration for MRSA treatment in your institute?
MRSA, it goes usually more than 6 weeks is what is preferred. So it depends. So you might have to do, you might have to follow the patient with the CRP and CRP levels. If it's coming down, you can actually go for stopping it between 8 to 12 weeks.
8 to 12 weeks. If the CRP is normal.
If it's all coming down, the patient is clinically responding, etc. If the patient is not clinically responding, you might have to do a repeat imaging and see if there's any other complication happening.
So you stop the treatment depending on the clinical and biochemical parameters in the case of MRSA.
Follow-up is always clinical as well as CRP, all those levels.
So there is not a definite duration?
No. It can go beyond
6 weeks.
So regarding this histopathology, I think a big spectrum of patients never reach the microbiologist. We have seen a lot of cases like that. So what do you recommend for our patients where I feel, okay, there is some granulation tissue, pathologists say there is some chronic infection, no big granulum and all. What is your recommendation for such patients? And how long the therapy be like?
If
No malignancy, not tuberculosis, but some long-term chronic infection, and all other parameters are negative.
if your osteomyelitis is still in picture,
Yeah, sure.
you can actually go for a long-term moxiflox treatment.
Matter how long you recommend? Is it justified or can
It's actually not what do you say, based on any guidelines.
Okay, okay.
So basically, we treat them for like I said, almost like an MRSA infection, 8 to 12 weeks.
12 weeks?
You'll actually repeat the imaging long later on, like after 2-3 months, and see if it's all.
Because some cases where we have done only given only 1 week of antibiotics, did a good surgical decompression, fixed the spine, compressed the spine. Within 3 months, it's already fused. The spine is already fused. So I personally don't believe there is role of antibiotics in such cases. That's my
But the thing is, in that even later on, there can be a recurrence.
Yeah, madam, but already the bone is fused. The recurrence chance is almost nil there.
Still, there are certain studies that actually show that there could be a recurrence.
Recurrence,
Yeah, especially when you have NTM or some anaerobic infection.
Yeah.
That is why we give it for MRSA and all this for a longer duration.
Okay. Thank you very much.
So I'll move on to the last scenario. So we have a 75-year-old woman who's a known case of systemic hypertension on medication. She did a bilateral TKR 6 months ago. Now she has come with complaints of pain in the left knee since the past 1 month. Local examination shows swelling with restriction of movements. Her total count is 8,000 and it's neutrophilic. CRP is 32, ESR is 40, and arthrocentesis is done, after your imaging, and gram stain shows budding E cells. Now your final report has come as Candida tropicalis, which is sensitive to fluconazole, and you're dealing with a periprosthetic joint infection or PGI. So you must all be familiar with this definition of periprosthetic joint infection. So either of one of these conditions is fulfilled, you can go for a diagnosis of PGI, provided you have ruled out other differentials. Now, these are what I have based my presentation on. So you have 2 of these from the American Academy of Orthopaedics as well as the IDSA, Infectious Disease Society of America. And again, Staph aureus is the most common, followed by all of this, and others are Candida NTM when you have a immunosuppressed elderly patient, etc. Now, you can also have chronic PGI that is more than 3 months, and these are usually associated with low virulence organisms like corns, etc. And here culture is quite important. Now, your routine examinations, as usual, interleukin 6 is something new, but we don't have this because this is actually 100% sensitivity, but we don't have it anywhere here. It's rarely done, maybe in CMC or like that. And the synovial fluid again goes for TCDZ culture, as well as again a PCR can be done here. Now, intraoperatively, histopath report actually is a strong evidence, and tissue culture, which can include one conventional culture as well as the TB culture if you're suspecting, and fluid, if you get the joint fluid, you can send it in an automated blood culture bottle, and implant sonication fluid for culture and PCR, and basically from the microbiology part, you need to incubate this for a minimum of 10 days. Now, what are the management levels? You all know. So if the duration of symptom is less than 3 weeks or the infection is within the 4 weeks, that is your early post-intervention period, and you have a stable implant, there is no sinus tract, and you have a culture report with an antibiotic, oral antibiotic with good biofilm activity, you can go for debridement with retention. Otherwise, if it's an intact or slightly damaged soft tissue and you don't have any oral antibiotic, you can go for a 1-stage exchange. If it's a damaged soft tissue, you have an abscess or a sinus tract, you go for a 2-stage exchange with the short interval between the 2 stages. and that is usually around 2 to 4 weeks. And if you have a MDR infection, a multi-drug resistant organism or a difficult to treat organism, in those cases you need to give a longer intervals of 8 weeks. And if the patient is inoperable, he or she is debilitated, then you'll need to go for a long-term suppressive oral antimicrobial treatment. In case the joint, you go for arthrodesis or something where you just remove the implant and you don't expect the patient to have a functional improvement, you go for that. So basically, one stage is for patients who have a good soft tissue, and two stage is what was being widely practiced in US, etc. So this can have two intervals, like you see. So basically, if you get an MDR infection or a difficult to treat, like for example a non-fermenter, like Stenotrophomonas, etc. In those cases, you can go for a longer interval. Between this interval, you're actually placing an antibiotic spacer. So the antibiotic spacer can contain the antibiotic whatever is sensitive. So there are formulations for that. And if you cannot operate the patient and you're leaving the joint as such, so you will need to go for a long-term suppressive antimicrobial treatment that is like for a lifelong. Yeah, so this is how is the duration, the interval that you give. So for debridement and implant, when you're going for a debridement and implant DARE procedure, you can actually cover the patient for 1 to 2 weeks with an IV parenteral antibiotic, preferably whatever culture that you've got, and then you change it into a oral regimen. In case of a one-stage exchange, it happens at that point, and again the same regimen is what we do. We give the parenteral antibiotic for 1 to 2 weeks, and then you go on to a oral antibiotic. In two-stage short interval, you give a space of 1 to 2 weeks between the removal of the implant and you're putting into a new implant. And you continue the IV antibiotic for usually one more week, and then convert it to a oral drug, whichever is sensitive. And two-stage exchange, again, a long interval is preferred when you have a difficult to treat, etc. And here you remove the implant, you give around 6 weeks, like totally you give a space of 8 weeks. In that 6 weeks, you give the IV antibiotics, you don't give the IV antibiotics for 2 weeks, and then again you do an implantation of the processes, and again you continue the IV, and for almost 6 weeks here. So basically you need to go for the least invasive treatment that also cures the infection. So it's a bargain. And totally you will need to go for a 2 to 6 IV parenteral therapy, and then it is followed by highly oral bioavailable drugs. So this oral bioavailability is important. And in case of gram-positive cocci, which you have recovered in your culture, a rifampin combination is indicated because rifampin has a higher action on biofilms that is produced on the processes. And in case of gram-negative bacteria, if quinolones are sensitive, that is the preferred antibiotic that you can choose. So when you have an implant retention, when you have an implant retention or you're going for a 1 or 2 stage short interval, you will need to treat the patient for totally 3 months. And in case of a hip replacement, which and for knee replacement, you will go for 6 months. For a 2-stage long interval where you have that 8 weeks interval, you'll only go for a total 6 weeks. Sometimes even this whole 6 weeks is going to be IV. I don't know what do you practice here. Do you people do 2-stage? 2-stage, okay. You go for the shorter interval, you place an antibiotic spacer. Okay. So, commonly, what is available here? Vanco, aminoglycosides, topramate. Okay. Yeah, yeah, yeah. Yeah, yeah. So there are formulations for that. So, yeah. Okay. Huh. Okay.
Usually, what is the reason for keeping 3 or 4 weeks as the cutoff for doing DARE?
Uh,
Is there any reason?
3 or 4 weeks for?
Debridement and implant retention. Your guideline says that if the diagnosis is within 3 or 4 weeks,
Okay.
all has to be satisfied. So it should be within
Yeah, because
3
once you
weeks.
go to the chronic side, there's a thicker biofilm being formed on the
So
processes.
the
It's
biofilm is
always better to remove the implant.
So is there any difference in the approach for shoulder replacement? Any difference?
Shoulder basically, actually, what we read is you see more of the skin flora coming there. So it's like propionibacterium,
okay.
all those things
So
come up.
does that change the indication for DARE?
It actually responds well to DARE.
Okay.
We actually don't do that much there. I'll refer and I'll tell you. I actually.
You're putting the spacer to keep the joint, that space there.
Yeah, yeah.
It's not for the, of course, you need antibiotics, but the spacer is used to make the ligaments
stable. Yeah.
Stable, that's all. Otherwise, you can use anything else instead of antibiotics.
You were referring to blood culture bottles in all the aspirates. You recommend using the blood culture bottle for all the joint aspiration. We use blood culture bottle for the joint aspiration. No, she is recommending Bactec bottle, which we use for blood culture.
Bottles.
We have to the yield will be higher in Bactec bottle. So when you do a joint aspirate, better to install in the blood culture Bactec bottle. It will be a green or tube will be available.
Actually, the incubation, it's kept for incubation for a longer period.
That may be one practice changing. But the yield will be higher, ma'am. Actually, the culture positivity yield will be higher. That's what So even in other.
Like brain heart infusion broth and thioglycolate. And always a Bactec bottle is not needed. Because in the laboratory we are using.
Even in other, when we are reading about other site of infection also, when you have a sterile aspirate, better to go for
the problem is our machine cannot accommodate all these bottles because we are receiving that we have to enhance this one, Bactec.
At least this joint aspiration we can consider. We can take Bactec, no? And if you see our joint culture and our
joint.
No,
they can.
Our joint aspirates.
But the problem is the aseptic precaution you should follow because the corns will grow and you may think that maybe from the skin.
No, if you see our data, the growth, the yield of a joint aspiration.
Okay, we can see. Okay.
Okay, next I move on to internal fixation associated infections. So again, it's almost similar to your PJI. So you need a histopath report, the culture and culture again from a single biopsy sample with that has shown a growth of virulent is enough to diagnose it, or you will need 2 biopsy samples from proximity of the internal fixation site, and that is for a low virulent organism. And again, if you have bone loss or fluid accumulation around the fixation or a draining sinus, all these comes, and I mean it can fit in the internal fixation associated infections. So actually they recommend 3 to 6 biopsies, and that too in close proximity to the device. And histopath actually plays a role in delayed or chronic presentations, where again imaging you might need it for serial follow-ups to see how's the local infiltration, etc. Now the treatment basically is device removal, that is your basic thing, but this again depends on the duration of infection. But you can actually retain the device even if it's a Staph aureus infection in early cases, because it has shown recovery with combination of fluoroquinolones and rifampicin. IV, again you follow the same dictum, that is IV followed by oral, and you need to go for at least minimum of 3 months of duration, and you have to look at the device and the healing part, that is your endpoint of treatment. Again, here they have there are studies that recommend a local antibiotic bead or spacer being kept. Okay, that's it. I mean, do you have any doubts in this? So we move on to the perioperative antimicrobial prophylaxis, generally for any surgical antimicrobial prophylaxis. So I believe you all use cefuroxime as your prophylactic antibiotic. So the timing again, you know, is 30 to 60 minutes. So that is the ideal ones that have been studied. And this going lesser than 30 minutes is not recommended, or more than 1 hour is again not recommended. When you have when coming to multiple doses of antibiotic prophylaxis, more than 48 to 72 hours of surgical prophylaxis is actually what do you say, it's more detrimental. They've shown resistant organisms developing because of it. So that is this study. And again, it's been here is an orthopedic study, and it's been again shown in cardiovascular surgery, the same thing. So these are the salient features. Your choice, your cefuroxime actually broadly covers a lot of the GNB and GPC, and usually dual is not indicated. And unless you have a proper indication, like a patient who's already been diagnosed with this, what do you say, a gram-positive culture, and you want to add teicoplanin, etc. The duration again 48 hours from 30 to 60 minutes before the incision. Antibiotic again for when you have a type 3 fracture where you're actually looking into a contaminated fracture, again they have again shown in this a maximum of 72 hours or 3 days is enough. And here your prophylaxis can go, you can go with piperacillin tazobactam because it has a beta anaerobic coverage. It's more broader for such only in case of these type 3 fractures. And basically it is about the timing of the antimicrobial prophylaxis rather than the duration that is actually going to give you a significance in your SSIs. And you also have the antibiotic impregnated bone cements. Initially, there were not much studies, the numbers were very low, but now there is one study in the Finnish arthroplasty register that actually shows a better outcome in patients who have these antibiotic impregnated bone cements placed in elective orthopedic surgeries. So, yeah, any doubts on perio?
Suppose Last week I deal with the pediatric cases. So I had a baby, 3 weeks old baby with septic arthritis of the hip joint. So 3 weeks. So we have got one OT. It is functionally aseptic. We follow the functional separation. So I am supposed to operate the patient last. So before that we have got a TKR. So I had to get another OT in some other complex and do the surgery as a first case. So what is the current evidence about architectural separation versus functional separation of septic cases?
Septic cases, it's an emergency procedure.
Yes.
Functional will do. I mean, basically, you're looking at the patient outcome there. So,
Functional separation is,
yeah.
so functional separation means that case has to be done as the last case.
Yeah,
Architectural means we have got a separate septic OT. Do you have a separate septic OT in Aster?
no, we don't have.
So suppose you have got one table allotted
Yeah,
to you.
understood. Basically, yeah.
Evidence about this architectural separation versus
I'll have to
functional
look
separation.
into that.
There was an article in the Indian Journal of Orthopaedics regarding this antibiotic prophylaxis. So they say something about the duration of the antibiotic prophylaxis. They say that most of the studies we take for this duration are Western studies. So in the Western countries, they do it in a laminar airflow with bodysuit, and the patient are kept in an orthopedic specific ward. But and the humidity is very less in those countries. But in our setup, there's a laminar airflow, but we don't do it a bodysuit. And our ward is not it's a mixed ward. It's an orthopedic patients, urology patients, ENT patients, and with the same nursing staff. So will this antibiotic prophylaxis for 3 days will be enough for in such a scenario, or will we have to increase the duration?
You're using cefuroxime. So if
No, I know.
anyways, I mean, that is not going to cover for the ESBLs or MDRs that you're going to get through your hospital.
Okay.
So that is not really
Okay.
helping much. So once the patient shows you that the infection is worsening, you're suspecting an SSI, increase your antibiotic rather than keeping it on cefuroxime.
Okay.
Is there a role for continuing the antimicrobial prophylaxis?
No, only in cases like you have an osteomyelitis case, you've debrided, or a PGI, or such difficult cases where you're suspecting an infection, you can continue the cefuroxime till you get the cultures. But
Okay.
otherwise, there's
And
no.
is there a role for linezolid as a prophylaxis?
Linezolid, like I said, the conditions, that's it. So, and that too, when you're taking up the patient for surgery, it's better to go for teicoplanin because it can go into the blood. Linezolid doesn't have that much action in the blood. So, better to go for teicoplanin. But again, till your cultures, I mean, like.
My question is, as an antimicrobial prophylaxis for a clean surgery,
No.
clean gram-positive coverage, and continuing that post-surgery, continuing the gram-positive coverage post-surgery without any documented infection.
Without suspecting an infection, there is very limited role. So, whatever it is, cefuroxime first. And unless you are very highly suspicious of a gram-positive infection, otherwise, this teicoplanin and linezolid has very little role. You're just going to get something resistant like a VRE later on.
One initial point regarding the implant infection. So we have got two types of implant. One is the load-bearing implant and load-sharing implant. So in case of load-sharing implants, like the intramedullary nails, we often like to keep the nail even if in case of severe infection. We have lots of cases where we make the patient walk with a cast or a brace and with the antibiotics covered. So I don't prefer implant removal in a load sharing device. Just addition to the what you told. That's
the
all.
nailing part and all.
Yeah.
Biofilm, that is the main concept in the long treatment duration for a prosthetic joint infection. So, especially when it's in a joint, your vascular supply is low, and these organisms, most of the organisms form a biofilm, and this biofilm is going to be resistant again. It's going to resist against the antibiotic that you're giving also. So that is why you prefer highly orally bioavailable antibiotics and rifampin, which actually have a action on the biofilm. So these are your key points that I want you to take from here. Basically, it's about appropriate sampling. That is the key to your right antimicrobial therapy, and that is going to lead to a better patient outcome. Now, generally, I told you swabs are not recommended here, and it's basically aspirates and tissue biopsies. Blood cultures are indicated only. Blood culture is the simplest thing that you can do, and sometimes you do get positives, and it will help you in your diagnosis. Second, joint fluids should ideally be cultured in blood culture bottles. For prosthetic joint infection diagnosis, 3 to 4 separate tissue samples should be submitted for cultures. And if you can do a sonication, I'll let you know what is the protocol. And that can be again in use because from the sonicated wounds, you get a disruption of this biofilms and you get better yielding. And when anaerobic bacteria is suspected, like in a hematoma, etc., PGI, etc., in those cases, they do recommend transportation in anaerobic culture, but I believe that that is not available in most centers. Even in ASTA, it's not there. So these are your take home, at least the first 4 points. And swabs only in one condition, that is your osteomyelitis. Okay. And you can go for molecular and serological methods for detection in the end. So like you have multiplex PCRs for detecting joint infection. Thank you.
Thank you, ma'am, for your excellent and informative presentation. Now I invite Dr. Jose Francis, HOD, Ortho Department, for hand-overing memento to Dr. Sneha. Dr. Sneha, she completed her MD in microbiology from JIPMER Puducherry, worked as study physician in Department of ID at CMC Vellore. She had several scientific publications to her credit. Currently, she is working as ID fellow at Aster Medicity, Kochi. Thank you, sir. Now I invite Dr. Dijo Davis for vote of thanks.
Good morning to all. So first of all, my sincere gratitude towards Dr. Sneha for enlightening us about the various aspects of bone and joint infection. And I also appreciate the efforts taken by the management and antibiotic stewardship team for arranging this program, honoring our request regarding a class for this bone and joint infection. And a big thanks for all the audience for making it a very interactive section. Thank you.